Society of Indian Medical Students of Obstetrics and Gynecology, SIMSOG, is the first all India OBGYN student society proudly established on International Women's Day 2024. At SIMSOG, we are a passionate community united by our dedication to women's health, and our mission is to create a dynamic platform for medical exchange among students and clinicians, fostering growth, learning, and collaboration. Our tagline, Breaking Boundaries, Building Hope, reflects our unwavering commitment to advancing women's healthcare through knowledge sharing, advocacy, and innovation. We are proud to share that we have successfully conducted impactful events recently, such as panel discussion on female genital cutting in collaboration with Equality Now, a live discussion on gender-based violence addressing critical issues affecting women globally, Academia Eternum, a 12-week research workshop skills aimed at enhancing research skills, webinar on USMLE residency pathway into OBGYN in USA, offering guidance for aspiring OBGYN professionals, academic exam guidance sessions for theory and practical exams for UG and PG.
I think Khushi has lost connection. So I'll continue with ma'am's introduction. First of all, we'll welcome everybody who's here for the seminar. Good evening. I'm Krishna Udasi. I'll be presenting one of the topics today, and I'm also managing this event along with Khushi. Ma'am, we'd like to welcome you to this event. Thank you so much for gracing us.
Thank
Everyone,
you.
Dr. Suyashree Palkar, ma'am, she's a senior obstetric sonologist. She's practicing in Mumbai. She's an honorary consultant at Norsoji Wadia Hospital in Mumbai. And with her vast experience in obsgyny, ultrasonography, and fetal medicine, she's been a constant source of guidance and support for SIMSOG. And we're truly privileged to have her with us here. And let's make the most of this. We'll start with today's presentation session with your permission, ma'am.
Sure. So thank you very much for this kind introduction, Krishna, and thank you for having me at this mentorship program. So a good evening and a warm welcome to all the students who are attending this program. Just a request, as we go along the presentation and the mentorship points, you write down your questions and keep them for the end to be asked after we are done with all the presentations and the mentorship points. So let's begin with the first presentation then, Krishna.
Yes, ma'am. Ma'am, first we have Ishika Pithwa with us. She's a second year student from Ahmedabad. And Ishika's topic is, she'll like start the presentation now. Ishika,
Okay, thank you, ma'am. Thank you so much.
Welcome, Ishika. Please start your presentation.
Yes, ma'am. Yes. Okay. So, good evening, everyone. My name is Ishika Pithwa. I'm second year GCS medical, second year student of GCS Medical College. I'm from Ahmedabad. My today's topic is ectopic pregnancy. So, ectopic pregnancy is like a very common pregnancy which are occurring in India nowadays. So there's a lot more things in the ectopic pregnancy we can like understand about this. So let's start. Now, first of all, what is ectopic pregnancy? Normally, the pregnancy happens in uterus, but the ectopic pregnancy is a pregnancy in which the fertilized egg implants outside the uterus, like fallopian tube, ovary, or abdomen, or even cervix. Fertilized, like human female reproductive system has various parts like uterus, fallopian tube, ovary, cervix, vagina, etc. But in this ectopic pregnancy, it is a pregnancy. Normally, the pregnancy happens in uterus, but ectopic pregnancy is a pregnancy in which the egg get fertilized, but get implants outside the uterus. So let's see where this implanted egg get implants abnormally in outside the uterus. There are various sites. Ma'am, am I audible properly?
Yes.
Okay. So these are the sites, this is the diagram of the female reproductive system. There are various parts of female reproductive system. This is the uterus. Normally the pregnancy, fertilized egg gets implant here. But the ectopic pregnancy can take place in the fallopian tube. The fallopian tube has 4 parts, that is cornua, the isthmus, ampulla, and infundibulum. So the ectopic pregnancy can happen at cornua also, in fallopian tube, isthmus site, ampulla, ovary, or infundibulum, and can be implanted in intramural site of the uterus or even at cervix, and can also implanted in the abdomen also. So these are the sites where the ectopic pregnancy can take place. So now let's take a look some key points regarding the ectopic pregnancy. The most common site of ectopic pregnancy here is fallopian tube. Mostly the fertilized egg get implanted outside the uterus, mostly in the fallopian tube. Now in fallopian tube, where? In fallopian tube, there are 4 parts: cornua, isthmus, ampulla, and infundibulum, that is fimbria. But the most common part of the tube affected is ampulla, which is followed by the isthmus. Now, many a times, this ectopic pregnancy gets ruptured at the sites, and there are specific different sites, and at which the different time it will get ruptured. So, if the fertilized egg get implants in isthmus, and if it get ruptured, it has probably that it will rupture at 6 to 7 weeks of implantation. In ampulla, if it gets implanted in ampulla, it will rupture in 8 to 9 weeks. And if it gets ruptured in cornua, it will rupture at 10 to 12 weeks. In abdomen, if it gets ruptured, then it will be last to be diagnosed. We can't diagnose early if the ectopic pregnancy has ruptured in abdomen. So we will look at the etiology and risk factors regarding ectopic pregnancy, why the ectopic pregnancy happens, what are the risk factors, what are the causes. So the biggest risk factor is the previous ectopic pregnancy. If there is ectopic pregnancy before in any woman, there will be scar formation, there will be fibrosis in fallopian tube, which will higher the chances of getting ectopic pregnancy again in that site only. The most common cause, that is the previous ectopic pregnancy was the biggest risk factor, but the most common cause is infection or pelvic inflammatory disease. Now, infection, if there will be infection in the reproductive system of the women, that if the fallopian tube gets inflamed or any other site of the reproductive system gets inflamed, there are chances that the ectopic pregnancy can happen, because it will leave a scar. It will leave a scar which will form fibrosis or sclerosis here, and it will obstruct the egg to implant in the uterus. So the implantation gets itself in the fallopian tube. There are fertility treatments. The women who are using fertility treatments, like if the IVF, in IVF, if the embryo gets implanted in fallopian tube by mistake, so ectopic pregnancy can happen. If there is a tubal surgery, or if there is if the female is using OC pills or in contraceptive methods, the ectopic pregnancy can happen. And mostly the smoking and tobacco also are the most common causes of the ectopic pregnancy. So these were the risk factors and causes of the ectopic pregnancy. Now, how the patient will present in our OPD if the woman is suffering from ectopic pregnancy. There are some clinical presentations by which we can understand that the female is suffering from ectopic pregnancy. So sometimes the female suffers from breast tenderness, fatigue, missed periods, mood swings, nausea and vomiting. These are the normal symptoms of pregnancy, rather the ectopic or normal pregnancy. So because the hormones, progesterone hormones are also high, so this will be the normal symptoms. But in ectopic pregnancy, the most common symptoms are vaginal bleeding. Now, why vaginal bleeding? Vaginal bleeding is mostly due to shedding of decidua, which is prepared for pregnancy, but that is not occurring in uterus. Our body realizes that the body like the uterus is not pregnant, or uterus is not letting is not pregnant, so the embryo will implant in fallopian tube, but like it will
Sorry to
make
interrupt
a
you, Ishika. Hello, hi. Just sorry to interrupt you. I think there is some issue with the slides. They are not changing. Yeah, now it changed. Can you
Yes.
I think you can start with the slideshow mode or something that will be better because we couldn't see the slide changes as you were
okay
explaining
ma'am,
before.
okay, just a second.
I think this is the slide which she's talking about breast tenderness, missed periods.
Yes,
So I think,
yes ma'am.
slide, Ishika, you're on the correct slide.
Yeah ma'am, yeah.
Yes.
It is it visible ma'am?
Yes, yes, very much.
Okay. So, vaginal bleeding is due to shedding of decidua, which is prepared for pregnancy, but that is not occurring in uterus. Okay, now the shoulder pain, neck or abdomen pain. How? Why? When fallopian tube get ruptured, sometimes the ectopic pregnancy can happen, and if it get ruptures, it will cause abdomen pain that is understandable. But eventually, this internal bleeding will irritate the diaphragm. If the fallopian tube get ruptured, there will be bleeding, and this internal bleeding will now irritate the diaphragm. And now the diaphragm and shoulder have same nerve endings, so the pain will radiate from diaphragm to the shoulder and sometimes to neck also. So can be so by this symptom we can say that the women can be suffered from ectopic pregnancy. Now the low blood pressure. Why the low blood pressure? Because if the internal bleeding is happening, there will be the blood loss. The blood loss, if the blood loss is there, blood volume is eventually get low. And so if the blood volume is getting low, the blood pressure will come to low. And dizziness and fainting are also the normal symptoms. Ma'am, is it visible? Next slide.
No, dear, next slide is not visible.
Okay, now.
No, beta, no.
Okay.
Yes. Yes.
Is it, ma'am?
Yes, visible. Yes.
Okay. So let's have a look at some investigations and investigations while we when we do for ectopic pregnancy. So there are the blood test and ultrasound scans. There are many lot of diagnoses, many lot of investigations we do for ectopic pregnancy, but blood test and ultrasound scans are very common. So we will have USG findings in ectopic pregnancy. Here in first A diagram, here we can see that it is empty uterine cavity. Now, life is not that easy. If the uterus is empty and the patient is suffering from ectopic pregnancy, the fallopian tube will be the commonest site. Life is not that easy. We have to diagnose further and further. Like if in the second B, the left adnexal mass, that is ligaments, the ligaments of the reproductive system like ovary and all are get separated from the left ovary, so we can see the left adnexal mass here. Second is the left adnexal the left adnexal mass is surrounded with the ring, which is also called the tubal ring. So, which is also called the tubal ring, which is called the ring of fire appearance. Now, if the in the D diagram, there can be the visible yolk sac, the small fetus within the mass, which is 6 weeks, 4 days older. And the last is that color Doppler image shows viability within the fetal pole. Now, patient with UPT, that is urine pregnancy test, if the patient presents with urine pregnancy test positive and increased endometrial thickness, so USD done very early or ectopic pregnancy is there. So now, how to rule out ectopic pregnancy? So if the patient is presented with urine pregnancy test and increased endometrial thickness and also normal adnexa, in such cases we have to rule out ectopic pregnancy if the on the basis of the measurements of beta HCG hormone. It is done till the time we reach a value at which gestational sac should be present. Like if the beta HCG levels reaches the 3510 international units per ml, at this measure gestational sac is visible. This is called the discriminatory value. And in uterine intrauterine G-sac is not seen at this level, then it is ectopic pregnancy. If the mass is present in the tube, if the mass is present in tube, then it is tubal. If not seen in the tubal, then it will be the pregnancy of unknown location. The beta HCG levels are measured every 48 hours till it reaches 3510 international units per ml. Now now we have ruled out the ectopic pregnancy. So now we will do further. Now what we will do further is now we have to manage this ectopic pregnancy. Now what are the different management techniques we utilize? So first is expectant management. Now what is the criteria for expectant management? Let's talk about that. So there is wait and watch criteria. If the beta HCG levels are less than 1500 international units per ml, that means the pregnancy has not taken a strong form at the fallopian tube. So we can wait and watch. So second is if the G-sac, if the gestational sac is small, less than 3 centimeter, we can also wait and watch for some time. And if the beta HCG levels are falling, that means that ectopic pregnancy is not getting hold, and it will get rupture and it will get cure itself. But if the patient becomes hemodynamically unstable, means if the ectopic pregnancy get ruptures or beta HCG levels are not falling and they are rising, then we first immediately abandon expected management. From expected management, we will shift to medical management. So what are the prerequisites for medical management is if the ectopic pregnancy has not ruptured or the patient is hemodynamically stable and gestational sac is less than 4 centimeter or less than 3.5 centimeter. Also, the beta HCG levels are more than 5000 international units. And if the patient has no contraindication to methotrexate, in medical management, we use methotrexate as a treatment. Why I will talk about that later. If the contraindication to methotrexate are anemia, leukopenia, thrombocytopenia, active peptic ulcer disease, pulmonary, liver, or kidney disease. No hypersensitivity to methotrexate. Only in this, if the patient has no any of the symptoms, we can use methotrexate. If the patient is also willing to follow up, only then we will go for medical management. The medical management is we will give methotrexate intramuscularly to the women 50 grams per meter square. Let's look medical management, how to monitor medical management. So when we give methotrexate, we will call this day 1. At day 1, we will measure beta HCG. Then after 3 days, on day 4, we will again measure beta HCG levels. On that day 7, we will again measure beta HCG levels. Now, first from first to fourth day, we will ignore beta HCG levels. If they're rising or falling, we don't have to worry. But between day 4 to 7, we are expecting the fall of beta HCG level by at least 15%. But if it does not fall by 15%, we will again start the methotrexate therapy from day 7 and cycle continues. Now, why we give methotrexate? Methotrexate is an antifolate drug. It will inhibit the dihydrofolate reductase enzyme, which will eventually not synthesize the folic acid. This is very the folic acid is very important for dividing for cells dividing. It will synthesize the DNA and which will produce new cells. But methotrexate inhibits this, and so methotrexate will eventually ends the ectopic pregnancy by rupturing, by regressing the cells, unnecessary cells. Now, after discharge, we have to call the patient for follow-up weekly till beta HCG levels reaches pre-pregnancy levels. That means when the patient was not pregnant, at that time the beta HCG was very low. So like beta HCG level were not there. So we have to call the patient for that up to that level. Now, if in case of pain, report emergency. If there is bleeding, and immediately report emergency, and avoid heavy exercise during this management. Up to how many months to avoid pregnancy after the ectopic pregnancy? So avoid pregnancy up to 3 months and use contraception. Do not take multivitamins. Multivitamins are not indicated to these patients because methotrexate is an antifolate drug. Now, if the medical management fails, then what we have to do is surgical management. Now, what are the indications of surgical management? There are many. If the beta HCG levels are more than 5,000 international units per ml, if the gestational sac has reached more than 4 centimeter or more than 3.5 centimeter with fetal cardiac activity, or if the patient is hemodynamically unstable, ruptured ectopic pregnancy. If there are any contraindication to methotrexate, we can't give the patient medical management. We have to opt for surgical management in this case. And if there is any failure of medical management, we should go for surgical management. Now, what we do in surgical management? In surgical management, we do 2 things: unilateral salpingectomy. Salpingectomy means removing the fallopian tube either by laparoscopically or laparotomically. Laparoscopically is by using camera, and laparotomy is open surgery. Now, if the patient is hemodynamically unstable, we should do laparotomy and not laparoscopy. Why? Because for this we have to do pneumoperitoneum, which will, if there is pneumoperitoneum, if we will inflate the peritoneum, it will put pressure on inferior vena cava. Eventually, if the inferior vena cava feels pressure, the venous return becomes reduced, and it will make the patient more unstable and will further reduce the blood pressure. So this is very dangerous. Earlier, we were used to do salpingostomy, but it led to recurrence. Like salpingostomy is an open surgery, but it led to recurrence of the ectopic pregnancy as stoma was left, so not commonly. So the only times we do salpingostomy is when there is already one salpingectomy done. The patient is not willing for salpingectomy. Now, what is salpingostomy? In salpingostomy, here in A diagram, there is the ectopic pregnancy you can see. And in this, we will do We will do the small linear incision on the site of the ectopic pregnancy. We will cut out and will uh, remove the ectopic pregnancy. Now, um, now we will stitch the site at which we had made the linear incision, but this is not commonly used because it will left stoma here and will lead to recurrence of the pregnancy. So this is all about salpingostomy. Now, in some hospitals, like if in government hospitals or low-level hospitals, if there is no beta HCG level monitoring system or UPT in urine pregnancy test, what we will do? So, if the patient presents with amenorrhea, pain and bleeding, there is an emergency due to increased BP and pulse rate. After examining the abdomen, we will find guarding tenderness. So when we will examine abdomen, we will find guarding tenderness and rigidity. So how we will differentiate? Because rigidity and guarding tenderness are many times symptoms of shock also, which are caused due to some other reason, not always ectopic pregnancy. So how we will differentiate between shock caused due to some other infection or due to ectopic? So pallor gives you the huge clue, but not always pallor gives you the huge clue. There can be the another reason also. So how do we diagnose ectopic pregnancy? So there's a technique called culdocentesis. Now culdocentesis is, it is the like a procedure from which from the like it is a procedure from which we can diagnose the ectopic pregnancy. How? So first of all, we will keep the patient upright for 2 to 3 minutes in this procedure and then tell them to lie down. Now we will insert the speculum into the vagina. We will lift the posterior lip so that we can see the posterior fornix of the vagina. Now, from the posterior fornix, we will try to aspirate whatever is there in the pouch of Douglas. Pouch of Douglas is also called cul-de-sac. So that's why this procedure is called culdocentesis. Now, if there is an ectopic, we will see blood in the syringe after aspiration. So if there is a ruptured ectopic pregnancy, the blood will not clot. Why the blood will not clot? Because the peritoneum will release some proteins which will not allow the ectopic blood to clot. If the blood gets clotted after some time, we will see after standing the blood for some time, we will see if the blood has clotted. That means you had done the procedure by mistake. You had done the procedure not correctly. You have done the traumatic tap or anything, or from wherever the bleeding is happening. So now immediately, if you diagnose the ectopic pregnancy, immediately take the patient for laparotomy. Why laparotomy? Because the patient is hemodynamically unstable. Okay, so ma'am, this was the last slide. And have a thank you. Have a nice day to all. Thank you for listening to me very patiently.
Thank you, Ishika. That was a good presentation. All right, so now I will take the students through my mentorship program. So just a moment. Okay, so let's start with the take-home message that I would like to give to the students. So I know what Ishika has said is all regarding a more of theoretical aspect, which was very good. But eventually, you're all going to turn clinicians, all right? So I would like to tell you that in women of childbearing age, all right, and especially in those with high risk factors, you have to be a ectopic conscious clinician. You must have a high degree of suspicion of an ectopic pregnancy, all right, always to be kept in mind so that you don't miss one, all right? Now, why? Because an ectopic pregnancy sometimes can present itself in an unusual way. There may be no history of amenorrhea, all right? There may be associated irregular vaginal bleeding, all right? And at times, even the beta HCG may be negative. So, in such patients, all right, who present maybe these kind of, history or symptoms, all right, those who have pallor, tachycardia, and patients with pelvic mass, remember, patient may well have an ectopic pregnancy. All right. Now, sometimes this is a point which I've come across in clinical practice. All right. In patients of ectopic pregnancy, when you insert the transvaginal probe, these patients have exquisite tenderness in the rectal area. All right. This may be because of the collection of blood in the pouch of Douglas. All right. Now, if there is a ruptured ectopic pregnancy, all right, resuscitation with arrangement of blood transfusion and laparotomy at the same time should be done, and not resuscitation followed by laparotomy. All right, one has to be quick. All right, give blood, take the patient up for laparotomy, and the signature is to be quick in and quick out. All right. Now, it is important to counsel the patient and her relatives, all right, that you have a high index of suspicion of an ectopic pregnancy, all right, before a laparotomy or laparoscopy, all right. And doing either of these will be life-saving if the ectopic pregnancy is present rather than missing out on a fatal diagnosis. Now, one does not need to feel ashamed if the laparotomy or laparoscopy turns out to be negative. At least you have averted a fatal mishap, all right? Remember, with assisted reproductive techniques on the rise nowadays, the occurrence of a heterotopic ectopic pregnancy, where there is a ectopic pregnancy in the tube and intrauterine pregnancy. So keep that in mind, all right? Now, remember to send the tube or the products of conception you do through a linear sulfongostomy obtained for histopathology. All right? That will prove indeed this was an ectopic pregnancy with the histopathology of the products of conception. Remember to give anti-D injection if the patient is rhesus negative. All right? Now, keep unusual sites of an ectopic pregnancy at the back of your mind always. Ultrasound and MRI are used for their diagnosis. Now, following ectopic pregnancy, as Ishika said, there is a high chance of recurrence of another ectopic pregnancy. Keep that in mind, and as a clinician, advise early supervision. Use of contraception after an ectopic pregnancy for 3 to 6 months is warranted. Keep this in mind. All these are important points. So now, shall we go ahead to the next presentation?
Yes, ma'am. We can start with Krishna. So Krishna Udasi is a final year medical student at RGMC Thane, and she will be presenting on the topic non-stress test.
Ma'am, is the screen visible?
Yes, it is.
Is my voice echoing?
Yeah, no, not at all.
Okay.
It's fine.
Okay. Good evening, everybody. I'll be presenting on non-stress test. So there are a couple of antenatal tests that we can do to determine the fetal well-being, and non-stress test is one such test. It is done to monitor the fetal heart rate with respect to the fetal movements. A similar test, if we do intrapartum, it is called as cardiotocography, whereas antenatal one is called as non-stress test. So, if the patient comes with complaints of decreased fetal movements, non-stress test is one of the things that we can do. It is a screening test for fetal well-being. However, we also try to do the modified Manning score test, which includes NST and amniotic fluid index. Just Non-stress test is the second best screening test that we can do, which is later confirmed by biophysical score. So, what non-stress test does is it assesses fetal heart rate with respect to the fetal movements. Now, fetal movements are spontaneous, felt right from the fifth month in primigravidas and multigravidas both. So, along with that, we monitor certain parameters like the baseline heart rate, the beat to beat variability, and the accelerations. These are the parameters of a non stress test. The principle is that whenever the fetus is moving, whenever the spontaneous movements are occurring, the sympathetic system of the fetus gets activated and releases catecholamines, and that causes an increase in the fetal heart rate. Yeah, a healthy fetus will have an increased heart rate on fetal movement. That is the principle. Now, this test is called as non-stress test because it is not causing any stress to the fetus. Tests like contraction stress test, which uses oxytocin to induce the fetus movements, that can put stress on the fetus. So it is done after 28 weeks, the non-stress test. Frequency can be once in 2 weeks, or in high risk cases, it could be once every week or twice every week, depending on the reactivity. Indications include decreased fetal movements. So the mothers are usually told to count the fetal movements, the number of the fetal movements. In case the mother reports with decreased fetal movements, NST should be performed immediately. Other factors like high risk cases where there's gestational diabetes mellitus or hypertension in pregnancy, or any previous history of stillbirth, any post-dated pregnancy, oligo or polyhydramnios, all these cases we have to do NST. Uh, this is the equipment. It is same. It is called the cardiotopography machine. Patient is supine or in semi-Fowler's position, which is 30 to 45 degrees elevated bed. Um, we have to make sure the patient has eaten so that there is no risk of hypoglycemia. Hypoglycemia can cause increased fetal movements. So the patient has to be eaten, and patient has to have the voided bladder so that it doesn't interfere with fetal movement detection. So there are two transducers. One is the ultrasonography transducer connected to the back of the fetus, which determines fetal movements. And there is another tocotransducer in case we are doing the CTG intrapartum, which detects the uterine contractions. Then these both are placed connected by a belt on the belly of the mother. A mother is given another button in hand, which she has to press whenever the fetal movements are being detected. This is done for 20 minutes. The chart gives the parameters that we want to assess. So, one, we have the baseline heartbeat. For 20 minutes, we have to determine what is the baseline heartbeat of the fetus. 110 to 160 is normal, less is bradycardia, more than 160 is tachycardia. Then there has to be baseline variability. Every beat, the heartbeat has to change. Normally, the variability is 5 to 25 beats per minute. Less than 5 indicates fetal hypoxia. Then there is fetal heart rate acceleration, which determines the result of the NST. Fetal heart rate acceleration is called as fetal heart rate increase by 15 ppm for 15 seconds on fetal movements. If there is fetal increase in FSR due to movements, it is a healthy fetus. And absence of acceleration indicates compromised fetus, which could have reasons like fetal sleep. We can use vibroacoustic stimulations to help the fetus go to active sort of sleep, which is the REM sleep phase. Then it could be hypoxia, it could be fetal acidosis, it could be narcotic drug use by the mother. Then we also have fetal heart rate decelerations, which we can see either in NST or CTG. They could be early due to uterine contractions, or they could be late. Late ones are pathological and need termination of pregnancy immediately. Uh, so the results of NST, they could be reactive or non-reactive or indeterminate. The reactive one means the fetus is normal and it has a predictive value for almost 1 week. It has to be done every week if it is normal also. So if it is normal, it is normal because there have been two accelerations of more than 15 bpm for more than 15 seconds within a 20-minute period. This is normal. It indicates normal autonomic function. If it is non-reactive, we have to repeat it for another 20 minutes. Uh, if it is again abnormal, then we term it as NST is non-reactive, which means for 40 minutes straight there have been no fetal accelerations because even after movements. Now, non-reactive NST indicates fetal distress or CNS depression or any CNS anomaly. And this, as I said, NST is a screening test. It is not a confirmatory test. In case it is non-reactive, it has to be confirmed by a biophysical score, which has a score of 0 to 10. 8 to 10 of biophysical score done after NST is normal. Less than 8, less than 6, it indicates chronic fetal hypoxia and has to be managed. There could also be unsatisfactory result in case the fetal movements are not properly detected, in case the mother is obese. There could be many reasons. So this is the chart of NST. In NST chart, there are only fetal heart rates with fetal movements. In CTG chart, there are fetal heart rates on upper graph and lower graph has uterine contractions indicated by the tocotransducer. The arrows on the top of acceleration peaks are the fetal movements, which are marked after the mother presses the button. So, pregnant females coming with a history of less fetal movements have to be monitored with NST. If it is reactive, it is a normal fetus. If it is non-reactive for the first 20 minutes, it has to be repeated again. And still, then it is termed as non-reactive NST and has to be managed further with biophysical score. And we can also use Doppler for further screening. So this is about NST. Thank you very much, ma'am, for the opportunity.
Yeah. So let me take you through the mentorship points.
Yes, ma'am.
Okay, so sorry for this delay. So as rightly Krishna said, you must know how to interpret the non-stress test correctly, both the normal as well as abnormal, to put it into practice. Now, as she said, an antepartum cardiotocography is also known as a non-stress test. Now, it is very important as a practicing doctor, before you use any kind of investigation, to know the history of the antenatal woman, whether she has any complications of pregnancy. All right. Apart from that, also clinical examination should include general and obstetric examination and any previous ultrasound reports that she should have. All right. And before applying the transducer and getting the non-stress test done, all these points, comprehensive points, should be in your mind. That is very important for you to categorize the woman, whether she's high risk or low risk, and will help you to interpret the NST accordingly. All right. Now, you should also ask history of fetal movements to the mother. Mother knows how her baby moves best. All right. A well moving fetus indicates a healthy central nervous system. All right. So you know you're on the right track. At the same time, if the mother says her baby is not moving too well, you're already on that extra alert guard. All right. Now, a very important point: before applying the electronic fetal heart rate monitor onto the maternal abdomen, it is important to record the fetal heart using a stethoscope, as if there is intrauterine fetal death, that transducer, all right, may record the maternal pulse from a major vessel such as the aorta. And the adult heart can also show baseline variability and accelerations, just as in the fetus, which can be mistaken for a fetal heart rate. So this is extremely important. All right. Now, as Krishna said, the non-stress test, the mother is given a button to press when the fetus moves, so that fetal accelerations can be coincided with the fetal movement, because the basis of the non-stress test is just that. All right. Now, also, you must write the mother's name and ID number on that non-stress test, all right, on the paper. Yes? Now, I'll show you a picture of a non-stress test and take you through that, all right? Now, let's go to that first. Okay. Now, this is a strip of a NST, all right? Now, can you see there is a vertical line measuring from 60 to 200? Now, this is placed at intervals of 20. Can you see 60, 80, 100, all right? And the line in between 60 and 80 is 70 and 90 and so on, all right? Now, this vertical line represents the scale for the fetal heart rate. If you see, there is another similar vertical line with the similar measurements, all right? Now, in between these two vertical lines, all right, there are 10 vertical lines. Now, these 10 vertical lines represent actually 1 centimeter each, all right? And this, because the paper speed is 1 centimeter per minute, so each centimeter, all right, represents 1 minute. So between these two vertical line, there are 10 minutes, all right? And these 10 minutes are each of 1 centimeter squares. So if you can count this 1 centimeter squares, there are actually 10 of them representing 10 minutes, because each 1 centimeter square represents 1 minute, which is equivalent to the paper speed. All right. Now, if you see at the beginning of this NST strip, all right, there is a stable fetal heart rate, all right, without any accelerations or decelerations, all right? And this is what you will utilize to find out the baseline fetal heart rate as well as the baseline variability, all right? Now you can see there is one bold line, all right? That's the 1 centimeter square that I'm talking about, all right? So if you see between the two vertical lines, we'll share this with you. Go back and read between the two measurements of the fetal heart rate. You will see 1 centimeter calculate, and this will be equivalent to 10 minutes, all right? Now, coming back to this 5 to 10 centimeter tracing, all right? Yes, where there is a stable fetal heart rate without any accelerations or decelerations. What you do is you take the midpoint of that wiggliness. Now, if you take the midpoint of the wiggliness, which represents the baseline fetal heart rate or the mean fetal heart rate, so can you see it falls between 130 to 140. So you know that is the baseline fetal heart rate. Coming to how to find out the baseline variability, again, take a tracing which is stable without any accelerations and decelerations. Find out the maximum peak of that tracing and find out the maximum trough. That is, trough is the bottom half of that tracing. If you see in one of them, the trough is at 115 and the upper one is at 140. So 140 minus 115. So the difference between the peak and the trough is the baseline variability. All right. Now, the normal fetal heart rate, as Krishna put it, is 110 to 150, but in a fetus which is less than 34 weeks, you can take the upper limit as 160 because the autonomic nervous system is still not mature. All right. The baseline variability is between 5 to 25 beats per minute. All right. So that should also be remembered. Now, the accelerations. All right. What are accelerations? Okay. So these are in response to fetal movement, all right? And you can see the accelerations of 15 beats per minute or more over a 15-second period. Now you see in one of those 1 centimeter square, you can actually see that the from the baseline of 130, it has risen to 170. So you know that acceleration is more than 15 beats per minute and lasting, because that square, all right, in which the acceleration exists represents 1 minute. So you can see by the time it's come down to baseline, it has lasted for more than 15 seconds. So this is exactly how an acceleration should be. All right. So you should have at least 2 such accelerations in a 20-minute period to prove that indeed this is a reactive trace. All right. Now, there should be no decelerations in a normal reactive trace. Okay. Go down. Okay, just 1 minute. Huh? Okay, so we've done all that, all right? Now, sometimes, so whenever you interpret or read a non-stress test, you should have 4 factors in mind, or you should read 4 points: the baseline fetal heart rate, the baseline variability, the accelerations, and if there are any decelerations. So every NST should be interpreted in those 4 points, all right? Now, sometimes you may just have a isolated sporadic deceleration, all right, which is very short duration, all right? But provided the baseline fetal heart rate is normal, the baseline variability is normal, and there are accelerations, this small sporadic deceleration could be because of a brief cord compression due to fetal movement, all right? And you will consider this test as normal, but also do another test of fetal well-being, like Krishna mentioned, the biophysical profile, just to be on the safe side, all right? Now, it is the evolution of a non-stress test that is important. Sometimes patients are admitted, say maybe for PIH, for monitoring. So if a lady comes on one day, all right, you do her NST and it's reactive, she comes back the next day, all right, or even a day later, the baseline fetal heart rate, which was say maybe 120, 130, suddenly becomes 150, all right? You should be on your guard as to why this is so, all right? Remember, every antenatal patient, all right, who is low risk or, that has a certain, finding at NST may become high risk. So every time the patient comes to you, you must ask her the same questions, go through the file. Maybe her blood pressure has risen, all right? Maybe today she's experiencing decreased fetal movements. So all these evolution of a non-stress test is important. All 4 points again should be checked, all right? Now, sometimes a non-stress test may be used as an admission test because it doesn't require a sonologist. Simple, you just strap on and do the NST, all right? Like I said, a previously seen antenatal patient who was low risk can become high risk. Keep that in mind. Next. All right, now see this, all right? This is basically you fit a knob or button to the mother to monitor the fetal movements, all right? Now, this may be misinterpreted as a pseudo distress pattern. You may think the baseline fetal heart rate is 160 and what you're seeing is decelerations. But no, actually, the fetal movements get recorded at the bottom of this upper trace, and you can coincide. These are actually many accelerations which are clubbed together, all right? So with the fetal movements, if you see these are many accelerations clubbed together, all right, it may give you an appearance that there is a pseudo distress, all right, that the baseline heart rate is 160 and that there are decelerations, but coincide these major accelerations or fused accelerations or many accelerations with the fetal movement. Call her back maybe 1 or 2 hours or 2 hours and or do another test of fetal well-being just to be on the safe side. All right, now this is what I want to show you. Here, the baseline fetal heart rate is normal, but Remember, the baseline variability is reduced, all right? And there are many spontaneous decelerations. This is a sinister tracing. This is a sinusoidal pattern. Like, what is a sine? Sine is a wave-like pattern, all right? This happens when there is fetal anemia. It can happen in, any hemolysis of the red blood cells of the fetus, or where there is feto-maternal hemorrhage, where the fetus has bled into the mother. If you ask the mother, how are the baby's movements? She will characteristic tell you that, no, doctor, the baby hasn't been moving too well. So remember, when you see patients in the antenatal clinic, apart from your blood pressure and your fundal height, remember to ask the mother for fetal movements. Very important. You may just save the life of a baby. All right. Now, this is the sleep pattern. All right. As Krishna said, yes, there may be 40 minutes where the baby is asleep. All right. So sometimes you may strap on the transducer, you'll see one acceleration and the baby goes off to sleep. All right. 40 minutes. Continue the tracing. Yes. Hope that the baseline fetal heart rate is within the normal limits. That's reassuring. Strap on for 40 minutes and the baby should wake up in 40 minutes time. All right. So that is a normal physiological sleep pattern of the fetus. Okay, so the last slide, all right? Now, so what is the normal pattern? All 4 points should be taken into mind. Baseline fetal heart rate of 110 to 150, less than 34 weeks, 160. Amplitude of baseline variability, 5 to 25 beats per minute. Absence of decelerations and presence of 2 or more accelerations in a 20-minute period. All 4 points should be there. Which are the suspicious patterns? Any one of the following, all right? Baseline rate of 150 to 170 beats per minute or 110 to 100 beats per minute. Amplitude of baseline variability between 5 to 10 for more than 40 minutes. Increased variability above 25 beats per minute. Absence of accelerations for more than 40 minutes. Sporadic decelerations of any type unless severe. And the last slide, the pathological pattern, any of the following, which demands either if the baby's preterm, you do another test of fetal well-being, like a Doppler flow studies or a biophysical profile. If it's term, you take action in delivering the baby. Which is the pathological pattern? Baseline heart rate below 100 beats per minute or above 170 beats per minute. Any of these following. Variability less than 5 beats per minute for more than 40 minutes. Periodically recurring repeated decelerations, severe, variable, prolonged decelerations, and the sinusoidal pattern of fetal anemia that I showed you. Thank you so much. Yes, Krishna?
Yes, ma'am. Thank you.
Yes, yes.
Yes.
Because, yeah, I wanted to show how you actually read the NST paper. Yeah, theoretically, what you've told me is absolutely right, but you should be able to read the NST paper.
Yes,
Yes?
ma'am. It was very helpful. Thank you.
So share this with your students so that they can go back and revise.
Yes, ma'am, for sure.
Yes, I'll be more than happy to do so.
Yeah.
Thank you so much for joining, everyone. So, firstly, I would just send a post-event form which is required for certification. So, everybody, I request everyone to fill it. Just a second. We would like to hear your feedback, and it would mean a lot to us. And on behalf of SIMSOG, I extend a heartfelt gratitude to Dr. Suyashree Palkar for sharing her valuable insights and guidance today. Ma'am, your mentorship has truly enriched our clinical and presentation skills, and I'm so glad that things that we are not taught in
Yes.
textbooks and our classes
Yes.
today, we have taken those key points, and that will really help us become better clinicians in the future. Thank you
Absolutely.
for, oh, yes, ma'am.
That was the aim.
And yes, ma'am. Thank you so
Alright.
much. And
Yes.
yes, also thank you to all the participants for patiently listening. And we look forward to seeing you at a future session. And ma'am, if there is anything that you'd like to say, it would be really nice.
So I really enjoyed sharing my insights with you. And I thank, SIMSOG for having me at this session and getting all your hard work, getting this mentorship program together, to Krishna and Kushi, as well as others in the SIMSOG, for the students who presented, for making the efforts, for getting the presentation, yes, and to all the attendees for taking their time off and attending this mentorship program. Thank you so much.